Okay, guys, welcome back. We shall be currently talking about a COPD update from the current edition of Harrison. So, once you studied about COPD, I'll just update your information for the new guidelines that they've added in the current edition. One, they have talked about what is called as MMRC grading for dyspnea, that is a modified medical research council. I'll just write it down. MMRC dyspnea index, like in cardiovascular system, they talk about NYHA grading, New York Heart Association. Here it is, a presence of a modified medical research council grading for dyspnea. So let us just quickly evaluate what it means, and then I'll tell you how to apply it for the update of COPD. Grade 0 I'm not writing because that is with strenuous activity, and that's a very, I would say, plus minus thing, because even you and me, like we doctors, keep on sitting most of the time. So if you are doing any strenuous activity, we tend to feel breathless. So that is something which is very skeptical, I would say, from a clinician's perspective. But when it comes to MMRC grade 1, you can remember it like this, that this person is trying to go upstairs and he's puffing and panting, his breathlessness on going on an incline. So the word to be remembered is breathlessness in a patient, especially on climbing upstairs or going up on an incline. In contrast, in grade 2 dyspnea, patient will have problems in walking even on a straight surface. He is gonna walk very, very slowly. The words of the patient will be that I walk slowly than my peers or other people of my same age group. Like this old man, he has a tendency to go for a morning walk. So he says that as compared to other people of my age, I tend to walk very slowly. And I said, okay, what do you do? What happens if you try to walk fast? He says, I just get so breathless that I can't keep pace with them. Or he has a grandchild who's running and this man can't chase his grandchild. Grade 3 dyspnea would be understood like this. This person will walk, let me say, 20 steps, then stop. He will catch his breath. Then he will again walk and will stop after taking, let me say, 25 steps. I encouraged him, try to do more, and I will notice the fact that this time he could walk maybe 30 steps and then he just says, no doc, I just can't sustain it anymore. So even with his best efforts, he's stopping in between. So difference between grade 2 and grade 3 in MMRC dyspnea index is that patient who's in grade 2, he will walk slowly than other people of the same age group, and grade 3 would be a person who will keep on stopping in between, and grade 4 is, I would say, too breathless to get out of his house. I mean, when you tell this guy, let's go out for a morning walk, he says, no, I just can't manage to go out. This is slightly different from what we study in the NYHA grading, the New York Heart Association grading, where we talk about like person is having difficulty in breathing on minimal activity. What is minimal activity? Like going to the bathroom. Minimal activity is like, let me say, changing a pair of clothes. That is grade 3 NYHA. But here, grade 4 is where he's too breathless to go out of his house when it comes to any physical exertion outside. Now, what they have done is that based on this, they have created a COPD severity index. One, I'll say like this, I have a patient in whom the MMRC, that is the Modified Medical Research Council Dyspnea Index, this MMRC dyspnea index is between 0 to 1. There is another patient in whom the MMRC dyspnea index is at least 2 or greater than 2. Then I would say that the patient is having more severe symptoms. Then I'll take into consideration exacerbations. These exacerbations can be taken on a scale of, let me say, 0 to 1 exacerbation in previous 6 months to 1 year in a patient, and there was no hospitalization in a patient. So I would say that this is a low risk patient because there was no hospitalization. In contrast, let me say, if in a patient the exacerbations of COPD are at least 2 in last 6 months to 1 year, or instead of this I say he has been hospitalized once in last 1 year, then I'll definitely say that the patient is a high risk patient. Based on whatever I said, that is the combinations here, the MMRC severity and the exacerbation severity, two things I'll say, dyspnea severity and exacerbation severity. He has categorized COPD into 4 categories, that is ABCD. Let me explain what he means by the word category A. Category A is a low risk patient, and this low risk patient is also having low symptoms. Let us understand what I mean by the word low risk. What I mean by the word low risk is that there has been no hospitalization in this patient in the recent 6 months to 1 year, and similarly in this patient the MMRC grade is 0 to 1. So low risk, low symptom will be the two entries of the table, which I'll just put markers on. I mean, if these two entries are present in a patient, I'll call the patient as a low risk, low symptomatic patient. On the other hand, if I just do a color change and highlight that a patient is having MMRC grade of at least 2 or more than 2 would mean walking slowly than peers, and he has been hospitalized last in 1 year, then I will call this chap as a high risk patient, since he's had hospitalization and there are obviously high symptoms present in this patient. So this is, like, you see, more of a management protocol that they have created, and then we can obviously fill in the data in between also. So you can just practice it by writing by yourself the inputs. And now I'm gonna create one more patient for you, low risk patient. So he is a patient who has not been hospitalized in last 1 year, but his MMRC grade is at least 2 or more than 2. So I'll put him as high symptoms. Let me take up another patient. He has been hospitalized once in last 6 months, but his MMRC grading is only 0 to 1. What we are doing is simply creating permutation combinations and categorizing COPD. So I want you to understand, if you can remember A and D, the remaining things will fall into place. That is, A is low risk, low symptoms, D is high risk, high symptoms. I'll repeat what I mean by the word high risk, high symptoms once again in case you missed it. What I mean by high risk is that the patient has had hospitalization again and again for COPD. High symptoms is MMRC grade of more than 2. So basically the point is that we would have to give more aggressive treatment to the chap in category number D as compared to the chap in category number A. And once they've created these categories, the potential question that they can put to you is the management protocol for these patients. So let's just write down these 4 categories, A, B, C, D. In category A, he says the fact that you could be putting the patient on any standard bronchodilator. You can be giving like a long-acting beta-2 agonist to the patient, and you can even change the various bronchodilators because some patients tend to respond better to one as compared to another one. You would have seen this very routinely. So it is simply the fact that bronchodilator usage in a patient for management of the symptoms of the patient. But as you can understand, the symptoms in the patient are not very, very severe. So I don't need to aggressively push bronchodilators on I would say regular basis. If he feels okay in between, I'll tell him, okay, you can switch off bronchodilators because patients don't like to eat medicines, you can understand. So bronchodilator as on need of the patient. But when it comes to category B, that is obviously a cause of concern. Why? Because in category B, we were having a patient who's having recurrence of symptoms. So he says that you have to give a daily LABA, or you will have to give a long-acting antimuscarinic agent. Now LABA, you are all aware of, that would be like salmeterol and so many others, but LAMA would be like ipratropium, or it could be tiotropium. So you could be giving a long-acting antimuscarinic agent because these are anticholinergics, right? So the anticholinergic would basically take care of the bronchospasm, especially seen in chronic bronchitis patients. So you could be giving either of these two. However, if there is still an exacerbation, so I'm writing the word fails in a sense that the symptoms are still present, then he says the fact that you can give for a short duration combination, and once the symptoms will improve, you can switch over to either of the two, whatever is responding better. Like LABA, most of the time patients will very well respond. But if we go to category C was where the word high risk came in. That means he's already been hospitalized, so I don't want to take a chance. So what I'm gonna do in this guy, I'm definitely gonna give this guy LABA and LAMA. If he improves with a combo, great, but if not, I will add inhaled corticosteroids. So I want you to remember the fact, MCQ wise, the fact that inhaled corticosteroids are to be introduced in category C of COPD severity index. It is just for this small thing that I had to go through the long statistical information for COPD before you, but you can very well understand the fact that that could be a question that he's having in his mind, that he can put up that what step would you put inhaled corticosteroids category C. That's a low risk, that's a high risk patient with low symptoms. High risk would mean hospitalizations, low risk would mean in a sense that low symptoms in fact would mean the fact that he can maybe walk on a on a straight surface, but when he goes up incline, that's when problem can occur for this guy. We go to step D, guys. For step D, that's again a question why I have gone into this discussion. I mean, I'm giving him everything that I have. I've given him LABA, I'm giving inhaled corticosteroids, and still the FEV1 of the patient is not improving. It's less than 50% of the normal. Then you need to add a drug, and the drug that you need to add for this patient would be roflumilast. So mainly the point is that you have to add a phosphodiesterase 4 inhibitor for management of this patient, and that phosphodiesterase 4 inhibitor that you need to introduce in this patient is the only one that is of primary concern for this patient. So these are the details as the update which has been added to the new edition of Harrison. So that is why I've decided to add this to the current discussion. Thank you so much.